Hello everyone and welcome to this webinar about blood gases. This webinar is divided in 3 parts, which you can follow either separately or as a whole. The first part is about the basics of blood gases, the second part about acid-base disorders, and the third part about the use in clinical practice. Each part will last approximately 30 minutes. In the end, I will end with conclusions and some exercises. For this webinar, I used several books, which you can see here. The first 2 are rather physiologic. The third one is a Dutch version, and some of the slides are unfortunately in Dutch, but that's only a few. And the last one by Lawrence Martin is probably the most clinical book, and the exercises which I will use are taken from his book. I will start now with the first part, which deals about the basics of blood gases. There are several topics. First, why a webinar about blood gases. Second, what to deduct from a blood gas, the normal values, and finally some abnormalities of the oxygen and carbon dioxide tension. The first question is why a webinar about blood gases. During my clinical work as an internist and intensivist with special interest in chronic respiratory insufficiency, long-term oxygen therapy and home mechanical ventilation, I started to appreciate the utility and importance of blood gases more and more, particularly when dealing with patients having respiratory insufficiency. In this slide, you can see the 2 forms of respiratory insufficiency. On the left, the partial insufficiency of the lungs, which is known as a pulmonary insufficiency and is characterized predominantly by a hypoxemia and often also some lower CO2 values because of compensatory hyperventilation. The therapy for this form of respiratory insufficiency is oxygen supplementation in whatever form. In the second part on the right, there is a respiratory pump insufficiency or respiratory insufficiency type 2. This is a ventilatory insufficiency characterized by elevated CO2 levels and usually a decreased oxygen tension in the arterial blood. It's also called hypercapnic insufficiency, and because of that, the therapy is usually mechanical ventilation. Whatever the type of respiratory insufficiency, it may develop acutely or chronically. Examples of acute respiratory insufficiency are pulmonary emboli, pneumonia, or cardiac insufficiency. Chronic respiratory insufficiency is usually the end stage of progressive chronic pulmonary disease and characterized with hypoxemia and/or hypercapnia. There is an increasing prevalence of this type of respiratory insufficiency as a result of better medical care. And finally, there is the acute on chronic respiratory insufficiency, which is often seen in patients with chronic obstructive pulmonary disease or COPD. Typical indications for performing blood gas analysis are disorders of ventilation, oxygenation, and circulation, disorders of the acid-base equilibrium, assessment of the severity of ventilation perfusion disorders, both at rest and during exercise, calculation of shunt fraction, and in general, you could say, for diagnosis and therapy. It is important to realize what we can deduct from a blood gas, what will be analyzed, which factors are needed for interpretation, and what are the causes of error. What will be analyzed depends on the type of blood gas analyzer. The type without a co-oximeter only measures pH, PaCO2, and PaO2. The other variables are not measured but calculated. On the other hand, an analyzer with a co-oximeter measures pH, PaCO2, and PaO2 like in the former analyzer, but is able also to measure oxyhemoglobin, carboxyhemoglobin, and methemoglobin. Please remember, a blood gas does not provide you with a diagnosis, but is, like fever, rather a symptom of a disease. Also, depending on the clinical setting, identical blood gas results can lead to very different clinical strategies. For the correct interpretation of blood gas values, we need several other data. First of all, data with regard to environment, like the FiO2. Did the patient get oxygen, and if so, how much, and what was the barometric pressure? Second, the clinical data which may be useful, like disease history or respiratory function, also mental functioning and tissue perfusion. And finally, data of additional investigations like former blood gas values, electrolytes, glucose, hemoglobin, hematocrit, creatinine, a X-ray of the thorax, and lung function investigations. In each blood gas sample, there may be causes of error. Sometimes there's doubt if a blood gas is arterial or venous. In general, a PO2 of less than 40 millimeters of mercury is seldomly arterial. If in doubt, please use a pulse oximeter. In case of an air bubble, oxygen diffuses from the air bubble to the blood, while CO2 diffuses from blood to the air bubble. As a result, PCO2 may be decreased, pH increased, and PO2 increased to such an extent that there may become a negative AA gradient. In case of leuko or thrombocytosis, due to the ongoing metabolism of the cells, oxygen may be consumed while CO2 is produced. As a result, the PO2 may be decreased while the PCO2 is increased and pH decreased. It is recommended to put the blood gas sample on ice while it is transported to the laboratory in this particular situation. When a very high PO2 is expected, like in calculation of shunt fraction, it is recommended to use glass instead of a plastic syringe because oxygen may diffuse through plastic but not through glass. Furthermore, for correct interpretation of a blood gas, it is very important to know if a patient did actually receive oxygen during the collection of blood or not. Notably, during a change of inspiratory oxygen fraction or ventilatory settings, one has to wait at least 15 minutes and probably 30 minutes before a new equilibrium is achieved and blood gas values may be interpreted correctly. In any case, each blood gas sample should be analyzed within 15 minutes. For a correct interpretation of blood gas values, it is of utmost importance to know the normal values. In the next slides, I will show you the normal values and explain you how particularly PO2 may be used in different calculations. In this slide, you see the normal blood gas values both in arterial and mixed venous blood. All values are given in millimeters of mercury. To convert these to kilopascals, you have to remember that 1 kilopascal is 7.5 millimeters of mercury. The most important values to remember are the PO2, which is usually between 70 and 100 millimeters of mercury, PCO2 between 35 and 45 millimeters of mercury, and pH between 7.35 and 7.45. This being said, it is important to realize that the arterial oxygen tension depends on several factors. First, there is altitude. The higher one gets, the lower the barometric pressure and the lower the oxygen tension. Secondly, when lying down, the oxygen tension is usually a little bit lower than when sitting in an upright position. Thirdly, age may be of importance, as may be seen from this formula. The older one gets, the lower his or her PaO2. And finally, there is the AA difference. the difference between the alveolar and arterial blood gas values. The arterial oxygen tension is given in an arterial blood gas, but the alveolar oxygen tension has to be calculated. For this purpose, we may use a formula as presented here. The first formula is rather complex, but the second one makes it a little bit more easy. In this formula, we can see that the alveolar oxygen tension is the product of the inspiratory oxygen fraction and the barometric pressure minus 47 minus 1.25 times the PaCO2. With a inspiratory oxygen fraction of 0.21 at sea level, the alveolar oxygen tension is recalculated as 150 minus 1.25 times the arterial CO2 tension. Although the AA difference depends on age, it is usually on room air around 15 millimeters of mercury. The AA difference does not only depend on age, but also on FiO2. In this slide, the AA difference is depicted on the vertical axis and the inspiratory oxygen fraction on the horizontal axis. For each AA difference, 1 and 2 standard deviations are given. You may see that at sea level and room air with a FiO2 of 0.21, the average AA difference is around 15 millimeters of mercury. The higher the inspiratory oxygen fraction, the higher the AA gradient gets. In addition to the AA difference, the relationship between the arterial oxygen tension and oxygen saturation is very important. In this slide, the arterial oxygen tension is given on the x-axis, while the oxygen saturation is given on the y-axis on the left side. On the right side, the oxygen concentration of the blood in the milliliters per 100 milliliters is given. As you may see, most oxygen is combined with hemoglobin in the form of oxygehemoglobin, and this amounts to roughly 21 milliliters per 100 milliliters of blood. Only a very small part of oxygen is transported in the blood as dissolved oxygen, and this amounts to roughly 2 milliliters per 100 milliliters of blood. The total oxygen transported is around 23 milliliters per 100 milliliter of blood, but most is transported as oxyhemoglobin. The oxygen concentration not only depends on oxygen saturation and oxygen tension, but also on the amount of hemoglobin available, as may be seen in this formula, which gives the oxygen concentration in milliliters per 100 milliliters of blood. In the picture below, you can see that at a partial oxygen pressure of 100 milliliters of mercury, the arterial oxygen concentration is around 20 milliliters per 100 milliliters of blood, while the mixed venous concentration is a little less, and usually around 15 milliliters per 100 milliliters of blood. The oxygen concentration describes how much oxygen a certain amount of blood contains, but it does not describe how much oxygen is effectively transported to the tissues. For the latter, we use oxygen delivery, or DO2. Oxygen delivery is the product of the oxygen concentration and the cardiac output. The latter is defined by heart rate and stroke volume. And stroke volume depends on preload, cardiac function, and afterload. In other words, oxygen delivery depends not only on heart function, but also on the amount of hemoglobin, the oxygen saturation, and to a much lesser extent, the PaO2, the arterial oxygen tension, representing the very small amount of dissolved oxygen. Apart from the first three factors given in this slide, oxygen delivery to the tissues also depends on diffusion from the capillaries to the mitochondria, to the oxygen affinity of hemoglobin, which may be changed, for instance, in carbon monoxide poisoning, and depends, of course, also on local blood flow. Next, I will show you the abnormalities of the oxygen and carbon dioxide tension with a focus on hypoxemia and hypercapnia. Both hypoxemia and hypercapnia may develop acutely, chronically, and intermittently, for instance, during sleep-disordered breathing, as in sleep apnea, and during nocturnal hypoventilation, as in patients with neuromuscular diseases. It is important to realize that there is a difference between hypoxemia and hypoxia. While hypoxemia is the shortage of oxygen in the blood, hypoxemia is the shortage of oxygen in the tissues. The latter may be caused by the first, as for instance in lung disease, but it may also be due to a decreased ability of the blood to transport oxygen, as in anemia or carbon. In this slide, the causes of hypoxemia are shown. On the x-axis is the PO2 and on the y-axis the PCO2. If the PCO2 is more than 45 millimeters of mercury, which is represented by this dashed line, there is hypercapnia. And if the PO2 becomes less than 100 millimeters of mercury, given by this dashed line, there is hypoxemia. The combination of hypoxemia and hypercapnia is only seen in patients with hypoventilation or having a low ventilation perfusion ratio. Most often, patients have a normal or even low PCO2 while having hypoxemia. A low CO2 may be caused by an increased breathing stimulus due to a diffusion disorder or low VQ ratios. The causes of hypoxemia may also be grouped according to the effect on the AA difference and the ratio between the oxygen tension and the inspiratory oxygen fraction. The causes of the hypoxemia may be either respiratory or non-respiratory. Importantly, a normal AA difference and hypoxemia is only seen in hypoventilation or in a decreased inspiratory oxygen tension due to a decreased oxygen fraction or decreased barometric pressure. In all other cases, the AA difference is increased. Now we will turn to the causes of hypercapnia. As may be seen from this formula, the arterial carbon dioxide tension depends on the carbon dioxide production and alveolar ventilation. The latter is the result of the total ventilation minus dead space ventilation. Hypercapnia may thus be caused by a decreased total ventilation, which is called hypoventilation, or an increased dead space ventilation, leading to ventilation perfusion imbalance. The latter may be caused by either alveolar dead space ventilation or a right to left shunt, either anatomical or functional. Clinically, hypoventilation may be caused by loss of central control in the medulla or pons due to overload of the ventilatory pump, as for instance in kyphoscoliosis, or due to strength of inspiratory muscle diseases, like in many neuromuscular diseases and for instance Duchenne's muscular dystrophy. In this slide, several causes of chronic ventilatory failure are presented according to origin. There are several diseases of the central nervous system, like central hypoventilation, central sleep apnea, a spinal cord lesion, and spina bifida. The largest group are the neuromuscular diseases with Duchenne's or Becker muscular dystrophy, limb girdle muscular dystrophy, dystrophia myotonica, amyotrophic lateral sclerosis, and Pompe's disease. Also, patients on the intensive care unit having a chronic critical illness polyneuromyopathy may have chronic ventilatory failure. A third group are patients with thoracic cage diseases like scoliosis, rheumatoid arthritis, and obesity hypoventilation syndrome. Pulmonary diseases leading to chronic ventilatory failure may be cystic fibrosis and chronic obstructive pulmonary disease. And finally, there is a rest group of miscellaneous diseases like facial dysmorphias. For the second part of this webinar, it is important to realize that hypercapnia has an effect on both the oxygen tension and pH of the arterial blood. As I have shown to you, the PaCO2 depends on the CO2 production and the alveolar ventilation. As CO2 production is usually stable, the alveolar ventilation is the most important factor determining the PaCO2. Meanwhile, the alveolar oxygen tension and thus also the arterial oxygen tension is dependent on the pCO2 in the arterial blood. Likewise, pH depends on the arterial carbon dioxide tension. The close relationship between the carbon dioxide tension and the oxygen tension is shown in this slide. On the x-axis is the alveolar ventilation, while on the y-axis the alveolar PO2, pCO2 and oxygen saturation are presented. On the right vertical axis the arterial pH is presented. If the alveolar ventilation decreases and alveolar pCO2 gradually increases, you may see that the alveolar oxygen tension, which is represented by this dotted line, decreases more or less to the same extent. In fact, for each millimeter increase in alveolar dioxide tension, the alveolar oxygen tension decreases also with 1 millimeter of mercury. However, due to its S-shaped curve, the oxygen saturation behaves differently. Oxygen saturation decreases only at quite low alveolar ventilation rates. In fact, with an alveolar pCO2 of around 50 millimeters mercury, the oxygen saturation may still be in the normal range around 95 or 96%. Finally, any change in alveolar ventilation and alveolar pCO2 may lead to a difference in arterial pH. thus stressing the relationship of PCO2, PO2 and pH. We have come to the end of the first part of this webinar, and for those who want to keep watching, I will continue now with the second part, which covers acid-base disorders. Thanks for watching so far.